Welcome to Symposium, Racism and Health Literacy. Thank you for joining us. This three-part series is conceptualized as an online march for health equity. Session 1 explores the role narrative plays in framing racism and health literacy, and Session 2 highlights and amplifies anti-racist health literacy practices. Session 3 bears witness to powerful stories of racism and health literacy and provides tools to help participants change the narrative. Racism and health literacy is a part of SEA's call for a racially just healthcare system and an end to the discriminatory health literacy and health communication practices that often leave patients and caregivers of color unseen, unheard, and unhealed. So a few guidelines as we hold space. Please be kind, keep an open mind, stay on mute, speak out in the chat box. You can also share your thoughts on social media with the hashtag #RHL23. We will drop a PDF of the event program into the chat, or you can find it on our website at www.sea.org. Okay. So the agenda for today's session, Racism, Health Literacy, and Communicating Across Power, is introductions, followed by our first speaker, Janet Ohene-Frempong, who will speak on the intersection of racism and health literacy. She is followed by Dr. Sayantani DasGupta, who will give the keynote on communicating across power. We will have time for a brief question and answer session before we close. And finally, we ask that you contribute to the learning by filling out a brief evaluation about the event and that you share in the evaluations any reflections you have on the program. So starting with introductions, my name is Arafat Omiridan. I am the Vice President of SEA's Board of Directors and a Provider and Life Sciences Partnership Manager, currently working at a mental health startup here in New York City, where I lead stakeholder management and project execution with health system, payer, and pharmaceutical company partners. My background is in community health, and I previously worked for a large health system in the Bronx, also in New York City, 7 adults who on average read at below a 5th grade level. My interest in health literacy led me to SEA, and SEA is a nonprofit organization founded in 2007 dedicated to improving the lives of patients, caregivers, and communities by improving health literacy. SEA's influence is strongest in the New York metro area, where we have provided in-person workshops to more than 12,500 community members at over 60 host sites, from Head Start to hospice, from Latinx high school students to LGBTQ+ older adults, from cancer survivors to newly diagnosed. Our work with community members informs everything we do, and its lessons are embedded in the trainings we have provided to more than 2,500 frontline professionals in health literacy best practices, including plain language, universal design, teach back, and narrative competency. It is evident in our plain language health literacy materials, which we have translated into 8 languages, and it is evident in the arts programming and events like this one we do to help professionals deepen their empathy and enhance their ability to communicate across health literacy divides. So SEA in the community, for those who cannot see the pictures in the slide, these are photos of SEA's work in the community, including a Cantonese language workshop on how to use the AR safely and effectively, a SEA staff member helping 2 older adults understand a healthcare proxy document, and a Spanish language health literacy workshop at a community center in New York City. SEA specifically works to help people gain the skills needed to be, in the words of Janet Ohene-Frempong, as well as they can be. Specifically, we empower patients and caregivers with our workshops, curricula, and materials. We train frontline health and social service providers in health literacy best practices including narrative humility, which Dr. Sayantani DasGupta will explain in her keynote. We provide plain language and accessible design services and consulting to help ensure materials are accessible to the broadest possible audience, including 1 out of 2 adult Americans who are functionally illiterate in the face of the healthcare system. And we advocate for policy change to ensure that health information and services are easy to access, understand, and use. Today's symposium is held in solidarity with the national observance of Dr. Martin Luther King Jr.'s birthday. For those unable to see the screen, there is a picture of Dr. King with his words he spoke in 1966. Of all the forms of inequality, injustice in health is the most shocking and the most inhuman because it often results in physical death. This is about 57 years ago. A lot has changed in that time and has been made clear during the pandemic that a lot has not. And without further ado, we are thrilled to welcome Janet Ohene-Frempong, who will define health literacy and discuss its intersection with racism. Janet Ohene-Frempong is a plain language and cross-cultural communications consultant with over 25 years of experience in patient-provider communications. She has conducted workshops and provided consultation on plain language and cross-cultural communications for a wide range of health information providers, including healthcare systems, government agencies, health insurers, pharmaceutical companies, medical publishers, health and human service agencies, and schools of medicine, nursing, and allied health. Mrs. Ohene-Frempong is a co-author of Literacy, Health, and the Law, an exploration of the health and the plight of marginal readers within the healthcare system, a monograph for health systems and pharmaceutical industry administrators. She is also co-author of Healthcare for African Americans in Rethinking Ethnicity and Healthcare, a discussion of the role of marginal literacy as one barrier to optical care. Ms. Ohene-Frempong has served on several national advisory committees and was a founding member of the Clear Language Group, a consortium of nationally recognized health literacy experts. She is a recipient of the IHA Health Literacy Hero Award, given by the Institute of Healthcare Advancement to recognize efforts in advancing the field of health literacy. She was a Blum Visiting Scholar nominated annually by the Maxwell and Eleanor Blum Patient and Family Learning Center at Massachusetts General Hospital. She is currently a strategic partner with the Institute of Healthcare Advancement, a non-for-profit public benefit charity dedicated to empowering people to better health. Thank you, Janet. We're happy to have you on board.
Unmute. Can you hear me? Can everybody hear me? I hope you can. All righty. Thank you for that very nice introduction, Arafat Omiridan. I hope I got your name correctly pronounced. I'm Janet Ohene-Frempong. We all have these long, unusual names, but hopefully beautiful names. I just want to thank Anna Allen and all of SAA for inviting me to address you today at this very important gathering. I always say yes to SAA. I hope they do not regret it. I am in the process of recovering from a bout with COVID in spite of all of my efforts over the last three years now to avoid it. I caught it, so I think I'm COVID free, but my voice is a little bit scratchy. I'm also awaiting major surgery in a few weeks, so I'm going to try to keep my voice even. And because of that, I told Anna Allen, I said, you know, it actually hurts a little bit for me to speak because of this surgery issue that I have. So I asked if I could read something that I wrote actually last year that addresses the issue that she asked me to address, which is the issue of racism and health literacy. And she said it would be okay. That'll keep me from going on and on and on, because I actually have a great deal of passion about this. I have a passion for holding hands with all people, who have been historically oppressed, targeted, or neglected, and holding hands with anyone, even someone who doesn't fall into any of those groups, who wants to help us fight against these assaults to our humanity and everyone's humanity. So this is a blog that I wrote, and when I'm done, if you like, I think Anna would put a link up to it so you could read it. Now, I don't know how Dr. DasGupta feels about it, but sometimes if somebody's speaking, I'm going to tell a bit of a story. Maybe you can close your eyes and maybe I won't, confuse or bore you. But let me do this so that it'll help me stay on track, because I only have about 10 minutes. This is entitled Promoting Health Literacy, and I rarely read anything, but I'm going to do it today just to stay on track. And I said, the question was, what does that mean? And I wrote this in a time of real turmoil. Unfortunately, the turmoil persists. But back in the summer of 2020, and again, if you want to close your eyes and listen to this, you may be able to hear me. I was invited to give a keynote presentation at the Colorado Health Literacy Coalition's virtual conference, and was kindly given some leeway regarding what to talk about. We were in the midst of a raging pandemic. We still are, I think. Minorities had been dying from COVID-19 in a magnitude that garnered national attention. You remember this. In March, Breonna Taylor had been ambushed and killed while sleeping in her own house. George Floyd had been publicly executed in May over the use of a possibly counterfeit $20 bill. Massive protests were taking place all around the globe. And we were facing what many thought was the most important presidential election in our lifetimes. I was in a dangerously emotional state. The organizers of the conference were folks I've known for some time and whom I hold in high regard. They gave me an entire hour. So I thought, where do we begin? Here's what I said. Let's first take a look at how we define health literacy. This was back in 2020. After all, how can we promote it unless we're clear about what it is? In 2012, in their article entitled A Review of Health Literacy and Public Health, a systematic review and integration of definitions and models, Christine Sorensen's team, they're over there in Europe, identified 17, this is back in 2012, 17 overlapping definitions that had been offered by researchers and institutions from 1998 at that point to 2009, 17 overlapping definitions. Yet one definition seems to have prevailed since 2004. This is 2020. It's been updated yet again, which is a good thing. Health literacy back then was called the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. And this is the work that SAYAD does. Thank goodness, especially in New York. That's my hometown. Thank you for the work you do. This readily embraced definition appeared in the seminal publication, Health Literacy, A Prescription to End Confusion. For any of you who are new to the field, find that, track it down, read it, at least browse through it. It was published by the Institute of Medicine, is now known as the National Academy of Sciences, Engineering, and Medicine. And that 2004 definition has provided structure and direction for the growing numbers of people who have focused on the issue of health literacy over the past 17 years, and now it's more than 20 years or so. How about focusing on staying alive, safe as well? Okay, that was my question. I've been working in the broader field of health communication. Notice I didn't say health literacy, I said health communication, with a focus on health literacy and health equity since the early 1990s. I'm going to be 75 next month. I've been around a long time. I've seen a lot. I have stories to tell. But anyway, back to that, I have found that unlike the terms computer literacy or financial literacy, the meaning of the term health literacy Interesting is not readily apparent to people who are not yet in the field, but who may be interested. The in crowd gets it, that's us, but not everyone else does. I have noticed that. And over the years, we've devoted significant amounts of attention to the task of sorting out what health literacy is and what it isn't. So more recently, and this was back in 2020, I've turned to a simpler way of conveying what health literacy means, at least to me, especially as we endure a surge of deadly social and political turmoil that even calls science itself into question. And that continues to this day. I suggest that health literacy, simply put, is, quote, your ability to figure out what's needed for you and for others to stay alive, safe, and as well as possible. This seems to resonate with those who are not in the field. It helps them to quickly grasp what we are all ultimately trying to do. We're trying to stay alive. We're trying to stay safe, and we're trying to stay as well as possible. So, zooming in via my laptop that morning in late September, I posed this way of looking at health literacy to the invisible group of conference attendees, and now I pose it to you. The current challenges of staying alive, safe, and well. Of course, there are many things that make staying alive, safe, and well, and as well as possible in everyday life a bit of a challenge. And we all know them. Consuming too much sugar, salt, and fat can lead to life-threatening conditions. Not wearing seatbelts can land folks in the hospital with broken bones and brain injuries. Our health, as well as our safety, are at stake. In addition, and you'll understand this, the lack of quality education, quality housing, a safe environment, a good job with fair pay, adequate transportation, affordable healthcare, and sensible policing, referred to as the social determinants of health, all combine to make it hard for people to stay alive and as well as possible when you don't have access to those things. And if you are African American in the United States, as I am, there are additional risks. For example, reaching for your driver's license during a police traffic stop, among other things, may not be good for your safety and therefore for your health. As of 2012, only one of the 17 definitions I thought was interesting to note, I think it was the one from Australia, of health literacy, mentioned safety as a concern. I say let's add it in because so many of us are not safe. So at the time I said, I think we need an extra dose of health literacy because things were in such turmoil. I think you remember them. They haven't gone away as far as I'm concerned. In many ways, they've gotten worse. But these are all things that make staying alive and well a challenge in everyday life. Then along comes a new and deadly virus. It was new then, it's not new anymore. In fact, some people think it's gone away, but it hasn't. I can tell you that, I just got it. Now, failure to social distance and wear a mask can result in life-altering consequences for many of us, any one of us. It has for me. It has changed what was going to be a simple surgery into now major surgery for me. Mixed messaging from elected officials has caused confusion and doubt, along with the death of hundreds of thousands of people. So surviving everyday life requires a good degree of health literacy. But I submit that staying alive in the age of COVID-19, along with the attendant social injustice and political turmoil, requires health literacy on steroids. Now, let me tell you what I mean by that. And I'll wrap this up in a while, so just bear with me. So I'm calling for us to expand the concept of health literacy, and here's why. Wrapped up in the turbulence of life in 2020, I failed to notice. Remember, I'm just getting ready to do this presentation out there in, well, it was virtual, but it was for the Colorado folks. I failed to notice that Chris Zarkadoulis was going to be the other keynote speaker at that conference. Known as a 1980s first-generation health literacy scholar, This health literacy concept goes back as far as the 1980s. We could have a whole talk just about that. But in 2005, she, with her team of writers, published an article entitled Understanding Health Literacy, an Expanded Model. Now, she did this with her colleagues, Andrew Pleasant and David Greer. And I'm sorry to say that Andrew Pleasant, we lost him just this past year, just recently. So there's Chris Sarkadoulis, Andrew Pleasant, and David Greer. It's called Understanding Health Literacy, an Expanded Model. I was amazed. I can remember this back in 2005. This is precisely the article that I had developed my presentation around back there in for the Colorado Prompt. And here she was, the author of that article. She was going to be the other keynote speaker. And in it, they suggested that becoming more functionally health literate actually requires some key abilities in 4 central domains. So here's a suggestion mission for us. I think we should promote 4 central domains of health literacy, because this definition has resonated with me since 2005, and I have continued to use it since then. Though we applied it to analyzing public health communication during the 2001 anthrax threat, some of you may not even be old enough to remember that. But in 2001, we had a terrible anthrax threat, and that's when they responded to this. And based on this model, I suggested to the conference attendees that I was addressing that promoting health literacy means taking the following steps. Remember, we're trying to stay alive and safe and as well as possible. Here's what we can do that. We can start by promoting functional or fundamental health literacy. We can promote, and we've been doing this, we can promote the skills and strategies involved in reading, speaking, writing, and interpreting numeracy, and adjust our communication accordingly. So if we're not teachers of writing and all of that, the least we could do is to adjust our communications so that we're communicating effectively across literacy levels, across languages, and across diverse perspectives. And many of us in the field have been doing this in one way or the other for years. But there's more. We can promote science literacy, promote levels of competence with science and technology, including some awareness of the process of science. To many, they take for granted the many benefits we enjoy because of what scientists have discovered and applied to make our daily lives more livable. The list is endless. But science has been under attack. Promoting cultural literacy. We can promote everyone's ability, even our own, to recognize our collective beliefs, customs, worldview, and social identity to interpret and act on health information. How important is this? It's important for us to come to terms with the fact that not everybody views the notion of health equity and inclusion the same way. In fact, we're at loggerheads with each other, and that's putting it mildly. We're knocking down and we're dragging out over this issue. We are, in fact, in the very throes of a culture war. And finally, last but not least, and I'm going to wrap up very shortly, we can promote the abilities that enable us, each of us, to become aware of public issues. This is really important, and to become involved in the decision-making process. Where would we be right now were it not those who peacefully demonstrated for social justice and voted in record numbers? Imagine where we'd be. We need elected officials who will fight to keep us alive and as well as possible. People assembled here today, we can have an impact, and we have. Though the political, social, and environmental events of the current times may seem almost apocalyptic, and they really do to me, our health literacy community has risen to the occasion and has worked hard to have an impact on people's lives over the past several years. When we communicate with people, when we teach students, or interact with patients, or oversee organizations, we can broaden the scope of our mission to include other domains of activity. It's not just about reading and writing, people. And this can help us to do even more to keep people alive, safe, and as well as possible. I don't want to go over my time. But I want to just let you know that in the past few weeks, I've learned a lot myself. Entering surgery, I know that bleeding is an issue. I'll give you an example. I've been drinking tea with ginger in it, and it occurred to me to go to the NIH and look up, possible, bleeding effects of ginger. And guess what? They're there. And there are a number of other things that we commonly consume that might not be the things to consume when you're going into surgery. People need to tell us this. Surgeons need to tell us this before we go into surgery. How would you know? You think you're doing something healthy, but you're not. There's so many things that we can do. I hope that you have an eye-opening and inspiring experience over the next few days. SAYA can always be counted on to open our eyes and open our hearts to these very, very important issues, so we can support each other as human beings on this troubled planet. Thank you for inviting me. Have a good conference.
Thank you, Janet, for the concise explanation and insight into the vast and complex issue. We are deeply honored to have you open this symposium. Okay. So it is my pleasure to introduce our keynote speaker, Dr. Sayantani DasGupta. Dr. DasGupta is a faculty member in the master's program in narrative medicine in the Center for the Study of Ethnicity and Race and the Institute for Comparative Literature and Society, all at Columbia University. Trained in pediatrics and public health, her work has appeared in journals including The Lancet, Journal of American JAMA Pediatrics, the Hastings Center Report, Literature and Medicine, Teaching and Learning in Medicine, and the Journal of Medical Humanities. She's an associate editor of the journal Literature and Medicine, and her current interests are in issues of narrative humility in medical education and practice, racial justice and health, diaspora studies, and science fiction or health futurities. She's also a New York Times bestselling children's author. We are honored to have her speak. Dr. DasGupta, over to you.
Thank you so much, Arafat, for that lovely introduction. Can you hear me? Thumbs up? Yes? Okay, perfect. And so I'll ask you for another thumbs up because I'm going to go ahead and share my screen. And I just want to make sure that, you've disabled participant screen sharing. So I just need to have that enabled so that I can share my screen. So thank you so much for having me as we sort that technical glitch out. I'm, as you heard, a pediatrician by training, although for the last number of decades, I have been teaching in the program in narrative medicine at Columbia. And let's see. I can share my screen. Beautiful. Thank you so much. Thumbs up. Everyone can see that? Yeah? Arafat, can you see that? Thumbs up? Yes? Beautiful. So I, for the last number of years, have taught in the narrative medicine program, which is a graduate program, but also taught the undergraduate students through the Center for Ethnicity and Race Studies and something called the Medical Humanities major within the Institute for Comparative Literature and Society. Let's see here. There we go. And for those of you who might not be familiar with the idea of narrative medicine, it's the scholarly and clinical field looking to honor the role of storytelling in the healthcare encounter. When it began, narrative medicine really began in the clinical context, in the medical school context, as an alternative to what was called at that point bedside communication or doctor-patient communication. And since that initial beginning, maybe 20 years ago, it's really grown into an interdisciplinary scholarly field as well as a clinical practice. It's deeply related to fields that are called alternatively health humanities, medical humanities, literature, and medicine, both across the country and across the world at this point. I actually really prefer, although I teach in the narrative medicine program, I prefer the term health humanities because I think it kind of takes away that hegemony of medicine, right? It includes all of us who are involved in healthcare, including family caregivers. And it broadens the scope of the work from narrative studies to kind of humanities in general. So my own particular interest in narrative medicine has always been at the intersection of narrative, so the stories we tell, health, defined broadly, including, as we just beautifully heard from Janet, Ohene-Frempong, including safety, right? Health is housing. Health is the ability to walk down the street, the ability to reach for one's wallet without being shot, right? So the broad understanding of health and social justice. So I'm deeply concerned, the title of my talk today is Narrating Across Power, but I'm really interested in, allyship across power, listening across power, activism across power. So narrative health and social justice has really been my entry point into all of my work over the last number of years. That said, I can start there. That said, when I was a young, newly minted pediatrician and medical educator, I came to my mentors and I said, I want to work in anti-racist healthcare education. And I didn't know what that looked like. And they said to me, oh, well, you want to work in something called cultural competency. And not knowing, what else there was for me, this is where I began my work. And what I'm going to do today in my kind of brief comments is trace the perspective of not just medical education, but I think anyone working in healthcare organizations, give us a sense of the frameworks that we can use from cultural competency to something called structural competency, and to, as you heard from Arafat, something called narrative humility. So let's start with cultural competency, which was the thing that I began my career in. What is it? Is it a way to train clinicians to serve diverse populations? B, a way to decrease medical errors? C, behaviors, attitudes, and policies that an organization can adopt to work effectively in cross-cultural situations? Or D, all of the above? I'm not going to put up a multiple choice or anything like that. I have a number of slides that will do this, but I think I've pretty much stacked my slides so that the answers are fairly obvious. So in my mind, it's all of the above. And so, yes, cultural competency perspectives can be a way to train clinicians, decrease medical errors. It can be institutional policy, but it really, in an ideal world, is all of the above. Now, in my own work in a narrative medicine classroom, I actually wouldn't begin with an ABCD multiple choice question if I was going to try to introduce a concept like cultural competency to my students. What I would do instead is start with a text. And so what I thought we could do here together is I could do, both some content teaching, but also be reflective on pedagogy, on the ways that I teach, by sharing with you a poem that we can listen to together called Immigrant Blues by Lee Young Lee. Unfortunately, due to the inadequacy of my Google slides, I'm going to have to reshare my screen here. Let's see. Okay. And make sure that I have my sound on. Oh, is it not allowing me to play the sound? It may not be for some reason. I'm going to try to play it, Arafat, but if it doesn't work, I'll just go ahead and read the poem aloud, since I know that my voice is working. Can people hear this? No. Oh.
I think you might need to read it out for us.
It's not working. Oh, the sound isn't working. Okay, I will go ahead and read it. My voice is less melodious than Liang Li, the poet, but you'll have to bear with me. Okay. Immigrant Blues by Li Youngli. People have been trying to kill me since I was born, a man tells his son, trying to explain the wisdom of learning a second tongue. It's an old story from a previous century about my father and me. The same old story from yesterday morning about me and my son. It's called Survival Strategies and the Melancholy of Racial Assimilation. It's called Psychological Paradigms of Displaced Persons. It's called The Child Who'd Rather Play Than Study. Practice until you feel the language inside you, says the man. But what does he know about inside and outside? My father who was spared nothing in spite of the languages he used. And me, confused about the flesh and the soul, who once asked into a telephone, am I inside you? You're always inside me, a woman answered, at peace with the body's finitude, at peace with the soul's disregard of space and time. Am I inside you? I asked once, lying between her legs, confused about the body and the heart. If you don't believe you're inside me, you're not, she answered, at peace with the body's greed, at peace with the heart's bewilderment. It's an ancient story from yesterday evening called Patterns of Love in Peoples of Diaspora, called Loss of the Home Place and the Defilement of the Beloved, called I Want to Sing, but I Don't Know Any Songs. So what I will do, slideshow from current slide. And let me go ahead and share my screen once again. I have a few other kind of audio clips, but I'll go ahead and skip them since our audio share doesn't seem to be working. But we can see the slides now, yes? Will somebody just yell at me if you can't? So what I might do in my classroom is instead of putting up an ABCD, allow people to kind of experientially understand a concept like cultural competency through something like a poem. And then what I might do is something like this. I might give them a writing exercise. So if we were in a classroom, I might say, pull out something to write with or on. But since we're in a Zoom webinar, I'll call it a thinking exercise today. And I'll invite all of you to think about the following questions. Think about a story told to you by a family elder. What title or name would your elder have given this story? What would you call this story? What would your children or younger people in the family call this story? In what language was your story told? Could it be told in another? What would it lose or gain? How was this story impacted by or reflective of your family's ethnicity and nationality, socioeconomic situation, geographic location, employment status, religious views, and other beliefs? And my point in kind of starting us off with, a poem and this thinking exercise is to say the following, is to say that, we all have culture, we all have stories. The question is, whose stories are centered and celebrated, and whose stories, because of structural oppression, are marginalized, silenced, ignored, moved aside in society. And so I just invite you to think about your own cultural stories as we continue to talk about cultural stories in medicine or stories across power in medicine. And just to give us a little transition, that's a picture by Victor Nye from Sarah Lawrence College magazine from a number of years ago. So I'll start with a clinical case. And again, I know that not everyone here is in direct healthcare practice. I know that many folks are advocates and activists or work in healthcare organizations. So I hope that this still resonates with those of you from all your different rich backgrounds. I am going to share with you 3 clinical cases over the next number of minutes. They're all pulled from other places. So this one is pulled from Arthur Kleinman, who is an anthropologist and psychiatrist who has taught up at Harvard for many years and wrote the book Illness Narratives. So clinical case 1. A Dominican immigrant to New York is HIV positive. Her infant son is also positive. Her husband died recently of AIDS. She's failing to bring her child in for his pediatric visits, has not filled a recent prescription for antiretrovirals. The pediatric clinic is ready to call child protection, but one compassionate, this part I added, compassionate social worker urges that this is undoubtedly due to the woman's cultural beliefs and some cultural competency should be used. Now, I told you already that I began my career as a medical educator in this thing called cultural competency, but soon I realized that it had some serious drawbacks. And this clinical case is going to explore some of those drawbacks. So let me ask you the question, and you can just think about the answers. Why is this mother being negligent? A, no one has explained to her that HIV is a virus, requires antiretrovirals. B, she doesn't trust the medical establishment in the US, believes they're experimenting on her son. C, she doesn't believe in biomedicine, is assured her son will improve through her spiritual practices. D, none of the above. And I think I've kind of stacked my question, so it's a little bit obvious. Because the answer is D, of course, none of the above. Yes, I suppose it could have been one of those answers, but those answers were fairly reductive, right? Those notions that I kind of put forth before you were fairly reductive. But yet they're pretty typical of the sorts of answers that a pure cultural competency perspective in healthcare suggests to us or leads us toward. Because in this particular case scenario, it was none of the above, and maybe our framing of this as negligence is actually the thing that we should be questioning. So what Arthur Kleinman suggests is a local world approach. In this particular case, he tells us that this mother is perfectly aware HIV is a virus. She actually has some nursing training. She's been working multiple jobs, and it's really been an issue of both timing and insurance coverage as to why she hasn't filled her son's prescription. Now, we see here that automatically assuming because she's an immigrant that somehow there's something called big C culture that's impacting her decisions might lead us down a really problematic road and an inaccurate road to explaining what's going on with her. Because the problems of a cultural competency approach, a pure cultural competency approach, as Kleinman and Benson discuss, are that it's based on the idea that culture can be reduced to a technical skill for which clinicians can be trained to develop expertise. Think about the word competency, right? Suddenly, how is one even like to measure something called competency vis-a-vis another person's culture? Culture is often made synonymous with ethnicity, nationality, and language, which it is not. It assumes that all cultures are homogeneous and static. It usually focuses on the client or other, ignoring the cultural beliefs and practices and background of the clinician or practitioner themselves. Now, despite all of these problems, this is in fact how I was trained in medical school, not by this terrible racist image. But the reason I put this racist image up there is I was taught in a fairly racist way when I was in medical school. I like to call it now the "it's a small world after all" approach. I was literally given a list. Here are 10 things that all Japanese Americans believe. Here are 5 things that all Dominican immigrants use as herbal supplementation. Here are 12 things that Muslims believe. And I was given these lists. I was told to memorize them. If I did well enough on my test, I was deemed culturally competent to treat those communities. And I hope that no one in any of your organizations is using a traits list approach anymore, but just be aware that many, at least I can speak only really for physicians, but many physicians who went to medical school like me were trained in these sorts of reductionist ways. There has been a narrative turn in cultural competency. So I was involved in that turn where we would hand, let's say, a group of trainees one book, a text, the spirit catches you and you fall down. No matter how good the text is, there's no way that one text, just like 10 traits, can make you competent to treat all people of all different communities. But there has been that kind of narrative turn where, let's say I handed a bunch of trainees, the spirit catches you and you fall down. We had in-depth discussions over a number of weeks, but that was it. And it was kind of an addendum to medical education. It was an extra hour or two at the end of the important subjects. And so students were already being given the very clear message that this was something extra to their work, as opposed to something central and critical to healthcare delivery. Arthur Kleinman suggests that instead of a cultural competency approach, we do an explanatory model or an ethnography approach, where we do something radical. We ask people what they think about their illness. We say things like, hey, what do you call this problem? What do you believe is the cause? What course do you think it will take? What does this problem do to your body? How does it affect your body and mind? What do you fear most about the condition or the treatment? So, right, that is actually a radical approach. You ask the person what they think is going on with them and what they believe, right, is the best approach to treat them and what their concerns are. However, there are also problems to this sort of approach, and we'll explore them through this next case. I'm putting this phrase in quotes because I find it kind of deeply problematic and racist, and I'll explain why in a moment. A morbidly obese African-American man in his 30s has diabetes, high blood pressure, and evidence of coronary artery disease. This is a clinical case I'm also borrowing from somewhere else, and so that's the wording they used. His primary care nurse practitioner is deeply worried about his future health. Along with his medication, she writes a prescription for increasing healthy fruits and vegetables in his diet and walking in the park for 20 minutes a day. That sounds good to me. On his next visit, though, the man admits that he has not filled either of these non-medication prescriptions. The NP, I've made this part up, who was an undergraduate anthropology major, asks him Arthur Kleinman's explanatory model questions. She asks, what do you call this problem? What do you believe is the cause? What course will it take? Et cetera, et cetera. And yet none of the answers that this gentleman provides does anything to move the question forward of why he hasn't fulfilled his non-medication prescriptions, right? We haven't gotten to the answer even through an Arthur Kleinman explanatory model or ethnography approach. So why is this man non-compliant? He hates his clinician. He doesn't understand the connections between food, health, and exercise. He hates himself. None of the above. Although these are clearly facetious answers, I do really like this notion of the non-medication prescription. If there's structural support for people to fulfill those non-medication prescriptions. So this man is non-compliant, which is a word that we should also challenge in medicine. What does that even mean? Due to none of the above. He, in fact, lives in a place where there are not a lot of fresh food stores. There are not a lot of outdoor spaces where you can safely walk. It's very hard to get to a grocery store with affordable, fresh vegetables. This, is an experience that used to be called a food desert, and I used to use that expression until a colleague and friend of mine reminded me, hey, don't use that expression anymore, because deserts are actually places where historically, our ancestors have grown food and lived and thrived for centuries. So this is a case that really demands not only cultural competency or an ethnography model, but something called structural competency. My colleagues, Jonathan Metzel and Helena Hansen, have defined structural competency as the trained ability to discern how a host of issues defined as symptoms, attitudes, or diseases represent the downstream implication of upstream decisions about matters like healthcare, food delivery systems, zoning laws, urban and rural infrastructures, medicalization, and even the very definition of illness and health. So what they're saying is you can't, as a healthcare worker, simply be worried about hypertension or diabetes you have to also look at things like zoning laws, grocery store availability, redlining, structural racism, right? All of those things aren't just simply things we must know about as healthcare professionals. They are within our purview to do something about, right? It's our obligation to also work on those issues. There's a video here, but since the sound, let me see here. Nope, the sound still doesn't seem to be working. I'm going to go ahead and just summarize what my friend Jonathan Metzel, colleague here, says, which is that physicians, nurses, healthcare workers have to be as actively concerned and working against upstream causes of downstream decisions as they are concerned and working against things like diabetes, heart disease, etc. So what structures or structural oppressions impact health? I think I've given myself away that I'm, tending to do all of the above on these slides. Work hours, flexibility, labor equality, transportation access, affordability, housing, childcare, food, immigration, health insurance, racism, or all of the above. Guess what? It's all of the above. So the 5 steps that they suggest is that we must recognize the structures that shape clinical interactions, develop extraclinical language of structure, rearticulate cultural presentations in structural terms, observe and imagine structural interventions, and develop structural humility. So what do we do next for our gentlemen? Do we rewrite the prescription in bigger letters? Do we organize a fresh food van that travels through the neighborhood? Perhaps the students at Vanderbilt did that. Do we organize clinic trips to a local farmer's market? Why not? Do we have a resource desk in our clinic waiting room which addresses structural prescriptions like food assistance, heating, housing issues? Sure. Do we work with an urban gardens group to create a community vegetable garden or outdoor exercise space? In my mind, it's all of the above, except for the writing the prescription in bigger letters. That was just silly. But certainly, right, structural problems require structural interventions. If you haven't seen Roger Doiron's TEDx talk about gardening, please do yourself a favor and go see it. He says gardening is a subversive activity. Food is a source of energy. It is also a source of power. When we encourage people to grow their own food, we are encouraging them to take power into their own hands, power over their diet, power over their health, some power over their pocketbooks. If you haven't seen Ron Finley's Gangster Gardener TED Talk, please go see that as well. Finley has a beautiful line. He says, gardening is the most subversive activity you can do, especially in the inner city. Plus, you get strawberries. So do go see both of those TED Talks. Now, those are about a certain sort of structural solution, gardening, to a structural problem, the lack of availability of fresh foodstuffs, as well as safe outdoor spaces for exercise. However, our clinical case too doesn't, our structural understanding cannot stop there. What we have to do is ask ourselves, what else we are diagnosing when we diagnose obesity? And the answer is deeply embedded in histories of structural racism and the way that communities of color's bodies and consumption, both eating consumption and purchasing consumption, have been policed historically in this country. Those of you who have been in New York City for a long time will remember the Bloomberg, when he was our mayor, the Bloomberg soda campaign that encouraged us to drink smaller portions of soda. Well, guess which communities got the majority of these public health ads? Yes, Black and brown communities got the majority of these public health ads. In addition, look at what insidious messaging this image is doing. We are meant to look at this man who's kind of slumped over, this person who I'm reading as a man of color. He's kind of slumped over, agency-less, powerless, so much so that he doesn't even have eyes, right? We're meant to look at his body, but he cannot implicate us in our looking. In case we miss the message, there's some crutches in the background here. this is a really deeply shaming and blaming image. It's saying, this man is at fault for what's happening to him. Hey, don't be like this man. And just to give you some perspective on how deeply problematic this campaign was, that was telling communities of color, you don't know how to consume correctly, we're going to tell you how to consume. This stock image of this gentleman was actually, they had his leg photoshopped out. This is not a gentleman. He happened not to be an amputee. He happened not to have an amputation, but just to kind of drive home the kind of ableist messaging, they photoshopped his leg out of this image. So we're not just dealing with structural understandings of things like grocery store availability. We have to deal with structural understandings of things like racism. So what if instead of that kind of a campaign, we did things like follow the health at every size movement, which takes people in the bodies that they inhabit and tries to pursue with them goals of health rather than goals of kind of shaming and blaming. Okay, so I'm almost done here. Clinical case 3, and hopefully we'll have plenty of time for question and answer at the end. Clinical case 3, this is actually a case that happened to me. And the reason I always incorporate it into my teaching is it's something that's really stuck with me, and I'll tell you why. A Pakistani American woman is having worsening anxiety attacks to the degree they're interfering with her job as a local school teacher. She's very tearful on her visit to the mental health clinic. It was actually the pediatrics clinic. I changed that. Reports being on probation at work, having trouble at home as well. There are various approaches we could take to dealing with this case. We could use a traits-based or a traditional cultural competency approach. We could investigate Pakistani belief systems, herbal practices, cultural stigmas around mental health, and that might be useful. We could also take an explanatory model approach. We could investigate this woman's own understanding of what's happening to her. Why does she think she's missing so much work? We could also take a structural competency approach. We might investigate possible unstated stressors like immigration status, unfair labor practices, or domestic violence at home. Now, given those choices, what do you think? Remember, she's Pakistani American. What do you think my colleagues in that pediatrics room went for right away? And unfortunately, these are just some really problematic quotes that have stuck in my mind to this day, because I was the only practitioner of color in that room. I was the only South Asian in that room. And I didn't know what to do. I was young, I was a trainee, and I didn't know what to do. And these were the sorts of phrases that were tossed around. Hey, aren't they pretty sexist? My colleagues became convinced that this was a situation of domestic violence because this woman was Pakistani, and they're pretty sexist, due to their backward beliefs and, Islam. And I was frozen like a deer in headlights. I knew how problematic it was. I knew how xenophobic and Islamophobic and racist it was, but I didn't have the tools, the language, or the power in that room to do what I needed to do, to kind of educate my colleagues. And that has driven me into this work more than anything else. So which of our previously discussed models might help? Second. I would suggest that the model that we need here is a different one than we've discussed already. It's narrative humility, which is humility towards that which we do not know, but that which we are still responsible for. I developed this idea of narrative humility as an expansion of Melanie Turvalon and Jean-Marie Garcia's notions of cultural humility, a practice dedicated to not just learning about them, whatever that might mean, but inward looking and self-reflection about us. It examines clinician biases, attitudes, frames of listening, expectations, and gaps in knowledge. It acknowledges that there are elements of the unknowable and unfamiliar in any patient or client or other person's story, not just the experiences of others, whatever that might mean to us. So we might ostensibly share a cultural background with somebody, but still there may be so many gaps due to our intersectional identities, right? In our knowledge of that person's story. And this last quote about narrative humility is actually from a student of mine. Our students are very often our best teachers. This was a student of mine who actually had MS and was in medical school and had felt like, due to the prevalent kind of ableism in medical school, she couldn't disclose that she had multiple sclerosis, so she kind of hid it. And she wished her clinicians would do this. She wished that they would try to understand, realize that you will never understand, but try anyway. And that's really the heart of this narrative humility perspective. So the truth of the matter is, in this particular case, this woman was experiencing anxiety attacks because, if those of you who are old enough to remember and who lived in New York will remember, post 9/11, Muslim and perceived Muslim communities in New York were deeply surveilled. Young men were being rounded up off the street outside of mosques and masjids. There was surveillance happening in community centers and schools. And while this might be a structural competency issue, and it could have been discovered by asking for this woman's explanatory model, what do you think is causing this problem? It requires narrative humility to uncover practitioner attitudes and biases. One of those attitudes and biases is this notion of brown women as perpetual sufferers, right? If you are interested in this kind of Islamophobic idea, please do refer to Leila Obulugad, my colleague at Columbia University, who wrote a book called Do Muslim Women Really Need Saving? Because that notion of saving Muslim women has become a kind of pseudo-feminist justification for warmongering by this country in various countries, Afghanistan, among many others. So what next? I'm just going to go ahead and draw to a conclusion now. What next? What I think I'm suggesting is that listening across power, narrating across power, being an activist across power requires a combination of approaches. It requires learning about somebody else's belief systems while making room for variety, asking them what they think is wrong with them. It's about learning on your own time, not expecting others to educate you, but learning on your own time histories of oppression, sociopolitical barriers to health, structures, and power. And what I mean by other people is, you don't ask a patient to, who's come in for their health issue to educate you on all these things. That's our job as healthcare practitioners to learn about, right? We also must examine our own biases, frames of listening, and expectations. And I think that we have to seek communities allies over false competency. The notion that one human being can understand and be the end all and be all, I think, is a fallacy. That's why we work in healthcare teams. That's why we have community members who are allies. So I would just ask you to think, what sorts of community allies could you call upon to help increase structurally competent care, narratively humble care at your institution or organization? Here are some examples of community allies, but remember, no one group can represent an entire community. And finally, I think I'll just end with the notion that we all have culture, we all have stories. Some stories have more sociocultural power or are granted more sociocultural power. Some are more frequently marginalized or silenced. Hearing the individual story is both to listen for particularity, the ethnographic approach, while placing the story in sociopolitical contexts, structural competency, and paying attention to our own frames of listening, narrative humility. I touched on this a little bit in the beginning. I didn't have a ton of time to touch on it, but I would also just encourage us all to think, those of us who are educators or do community-based education work, classroom education work, think about not just what we teach vis-a-vis power, anti-racism, but how we teach it, right? So pedagogy is a parallel process. If we teach these content issues in a top-down hierarchical manner in which we are the knowledge holder and our learners know nothing, we're replicating the same kind of harmful power dynamics, right? How do we draw from, let's say, Brazilian educator Paulo Freire or Black feminist educator Bell Hooks to say pedagogy is a parallel process? Stay away from toolkits, as Audre Lorde tells us. the master's tools will never dismantle the master's house. And finally, I was going to end with this, but I think what I will do is invite you all to listen to it on your own. Lucille Clifton's beautiful poem, Won't You Celebrate With Me? She reads it at the Dodge Poetry Festival. I was going to end with it, but I'll ask you all to listen to that on your own time and simply thank you all for inviting me into community with you today.
Thank you so much, Dr. DasGupta. I really enjoyed that last quote about the master's tool. I think that was a nice touch. I guess we would now open this up to a question and answer session. And then Derek, I know you're going to be sharing some of the questions for Dr. DasGupta to answer from the chat.
There is one question about what is alternative to the phrase food desert.
Oh, I think someone answered it, no? They were suggesting food apartheid. Who was it? Let's see in the chat. Someone was suggesting in the chat, but now I've completely lost track of it. Someone was suggesting that in the chat. Does anyone else have other suggestions or thoughts? You want to drop them in the chat? Because I've tried to stop using food deserts, but I haven't come up with a good alternative. There was one here suggested. I don't know if other people have other ones that are suggested. Food swamp, says someone. But certainly, you know, I think that the most important point being, you know, no matter how, you know, long you've been working in a particular field or how entrenched a certain idea or phrase feels to you, I think being open. Oh, here we go. Thank you. Larissa Yoshino is saying, I've heard food apartheid because it's man-made, not nature-made. I think that's a beautiful explanation for why that phrase. Yep, food apartheid is pretty well known and appreciated. Deserts and swamps are full of life. I'm just reading out the chat. I'm just here being a learner and a reader. Were there other questions from the chat that we wanted to get to? Here, Susan is saying, can Dr. DasGupta share the name and book title? It's Leela Abulugad's Do Muslim Women Really Need Saving? I'll try to type that in as we're looking at the other question.
There's a couple of questions that are somewhat related. Nicole asked, how can narrative humility best be used outside of the education environment and healthcare?
I mean, I actually, look, I'm obviously entirely biased because I came up with this phrase. So, you know, take my thoughts with a grain of salt. I think that narrative humility is a way to approach the world, right? It's, I use narrative humility in my classroom as an educator, realizing that just because I'm in there with a certain set of tools, a certain set of expertise, I don't know everything. I'm there to learn in community as much as everyone else is. So that's a classroom context. In a clinical context, similarly, you know, people come with medical expertise, but you're not the authority on what's happening to this other person across from you's body. They are, right? So there's humility. But I think in any interpersonal context, the notion that we must or can engage with the other person's story without the expectation that we will fully understand everything about them through that process, with the full understanding that there are going to remain many, many aspects of that person that are unknown to us and unknowable to us, and that what we must remain humble, try to understand, realize that we'll never understand, but try anyway. So in my perspective, it's you know, it really is a way to approach relationships in general. Collective experiences, that's interesting. I'm just reading a comment that came up in the chat. I often think how to balance the unique individual experiences we all have with collective experiences. So yes, all that I just said about narrative humility was really an interpersonal, right? And in an interpersonal manner. But the reason I think that we need all of these perspectives together and they all have something to teach us is, you know, there's knowing another person's belief system, being, you know, on a journey of discovering your own prejudices, biases, expectations, and, you know, simultaneously approaching individual stories within structural contexts, right? So knowing that, you know, Bloomberg public health image, yes, is about soda consumption, but it's also deeply embedded in historical and structural oppressions, right? Historical and structural stories about whose bodies are normative, who is consuming in the right way, what, you know, bodies of size mean or imply, right? So there's structural stories always necessarily framing our understandings of individual stories, if that makes sense.
Thank you. This is from an anonymous attendee. What do you think about the anti-hijab protest in Iran?
Oh, goodness. I think, you know, folks should wear or not wear what they want. But more importantly, I'm, you know, so you know, I'm thinking of France even as I'm thinking of Iran. I also think that, you know, the suppression of voices of protest and the suppression of young people standing up is really a terrifying thing that we're seeing, not just in Iran, but across the globe, you know, and so I worry deeply about voices of protest, voices of resistance being met with violence in any context.
Thank you for that. And there's a question about, would you agree that empathy is the basis for narrative humility?
You know, I'm not sure. It depends on how we're defining empathy. I think there have been, at least within the health humanities fields, some framings of empathy that I don't find particularly humble. So to me, you know, the reason I kind of went to that notion of narrative humility is I loved Tervalan and Marie Garcia's notion of cultural humility. I just thought, well, cultural humility sounds like something you do. It's like cultural competency you do when somebody of another culture approaches you. Narrative humility tells you that all stories, all people's stories, have elements of the unknowable. Even somebody who ostensibly shares all of your identities, you know, that person still has elements of the unknowable, and you can try to understand, realize you'll never understand, and try anyway.
Thank you for that. Cindy has asked, can you elaborate on the issue of the phrase morbid obesity? She says in the chat that she was weighing in at 159 pounds and was told that she was morbidly obese. Go figure.
So even from that last, I imagine sarcastically said, go figure. You know, I think that when we use the phrase obesity, I think we're drawing on what I said in my talk, kind of structural and historical, deeply kind of racist notions of whose bodies and what sizes are normative, acceptable, etc. There's a long history. There's a whole field called fat studies and fat activism. And if you kind of look into, there's a beautiful text called the Fat Studies Reader. If you look into the work of, you know, historians looking at size, you'll see that there's a real kind of long history, gendered and racialized history of the way that bodies are othered. And so obesity itself, right, is a, deeply fraught term. And then I think morbid obesity, like, what is that? I think, it smacks of the same kind of shame and blame that Bloomberg public health image did. And it worries me, right? It worries me when we use phrases that automatically then will trigger other stories in practitioners' heads, And so I think that we should just be more, absolutely, an individual has the right and the need to talk to their healthcare practitioner about their body, their weight, whatever else they would want to talk to their practitioner about. But I think that those sorts of labels have so much cultural meaning now that they worry me when we use them kind of, willy-nilly without an examination of their historical implications.
Thank you. And this goes into the territory of another ism. Somebody says, considering the older healthcare practitioners who may have deeply ingrained racist practices from decades of experience, are you hopeful that that can be undone? And if so, how?
That's the question of the hour. That's the question of the hour, isn't it?
Yes.
So I really believe that if we only do, and excuse me, I only know about medical education, or certainly health humanities or narrative medicine education, so I'm speaking from that perspective. If we only, rigorously train young trainees, medical students, say, in structural competency, in narrative humility, in anti-racist practice, a lot of the work I've been doing lately has been around issues of abolition. So really thinking through the deeply racist and carceral logics that medicine is built on, and thinking through like what are models that we can change medicine towards a more anti-racist future, right? How can we look at Black Panthers free health clinics, or the Young Lords, taking over tuberculosis ban and bringing it to the community? How can we look at community-based mental health organizations that are being called instead of calling 911 when somebody's having a mental health crisis on the street, right? How can we look at those sorts of models to change medicine? So anyway, if we're only training young folks coming into the field in these sorts of framings, then we're doing them a deep injustice, because the moment they get into a hierarchical relationship in the hospital or the clinic, or wherever their training brings them, and somebody senior to them says, no, that's wrong, that's not the way we practice, don't do that, that's ridiculous, then they get squashed, right? So I think that the work has to happen, the anti-racist medical work has to happen at multiple levels of power, and it really is about a cultural shift. But in a sense, I really draw inspiration from people speaking of abolition, like Ruth Wilson Gilmore, like Mariam Kaba, who say, we have to envision the world we want to live in. This may be a step-by-step process, but, deep and broad cultural shift may take time. But if we don't kind of put it out there as our goal, we're also not working toward it. So I do think that, it has to be deep cultural shift at all the levels throughout the hierarchy of medicine, or else we're just setting up young people to kind of get squashed, which is not what we want either.
Thank you so much. And I think we'll pause there, Arafat, and I'll bounce it back to you. And Arafat, can you unmute?
Oh, yeah, I was just trying to unmute. So I guess, are we done with the Q&A session? Derek? I can hear you.
Oh, yes, we have about 5 minutes left. So if you'd like to do a closing and a thank you, that would be awesome.
Awesome. Yeah. Well, thank you again, Dr. DasGupta, for your riveting keynote address. And thank you to Jane at Ohene-Frempong for opening the symposium up with your definition of health literacy and discussion of its intersection with racism. We are deeply honored to have the opportunity to bring your insights to people on the front lines of health communication. We have a few additional thank yous to shine light on the off-screen efforts. And we would like to thank the co-creators of this event who came together in 2020 to make this event a reality. Maya Reed, Tomi Shonton, as well as CAR board members, Valerie William Sanchez, and CAR board president, Derek McCracken. We would also like to thank Jay Dickinson, who has worked tirelessly on this 2023 effort and who will be tomorrow's host and speak on Thursday. And thank you to everyone in attendance. We look forward to seeing you for the next 2 sessions of the symposium, both at the same time, 3:30 to 5 p.m. Eastern time, and you could use the same login as today.